Hello and welcome to Surgical Options for Veterans Living with Parkinson's. I'm Annie Long, Associate Director of Community Programs at the Parkinson's Foundation. We are delighted to be here with you today. From all of us at the Parkinson's Foundation, and as the sister, daughter, and granddaughter of veterans, we appreciate all the sacrifices you and your family have made in service to our country. Our program today will consist of presentations from Parkinson's experts from the Minneapolis VA health system, and the exciting update of a workup process for consideration of deep brain stimulator surgery, now available at the Minneapolis VA for veterans within VISN 23, North and South Dakota, Iowa, Nebraska, Western Wisconsin, Minnesota. Please submit any questions you have for our presenters via the Q&A icon that appears in the black banner at the bottom of your Zoom viewing panel. We will get to as many as we can after each presentation and at the end of today's program during our final Q&A. We want to thank today's sponsors, Kyowa Kirin, Amneal, and Boston Scientific for their support. Welcome to those joining us for the first time. I would like to take a minute to share the mission and work of the Parkinson's Foundation. We are the nation's largest community for people living with Parkinson's. Our mission is to make life better for people with Parkinson's disease by improving care for everyone, advancing research toward a cure, and empowering and educating our global community. We offer an extensive set of resources that include our website, Parkinson.org, our free educational book series that you can download or order, a library of recorded podcasts and webinars, and our hospital safety kit, also called Aware in Care. We also offer our free national helpline, which is staffed by Parkinson's specialists who are ready to answer your Parkinson's-specific questions and provide support to both you and your care partners. To access our resources and support, please contact our toll-free helpline at 1-800-4PD-INFO. You can also email them at helpline@parkinson.org. You can also visit our website to order materials at parkinson.org. Part of the Foundation's commitment is to reach every person living with Parkinson's disease. A critical way we do this is through our partnerships. And with more than 100,000 veterans living with Parkinson's disease, the Foundation has established a formal partnership with the Veterans Administration with the overarching goal to improve the quality of life for veterans living with Parkinson's and their care partners through greater access to education, resources, and support. We have created a webpage dedicated to veterans living with Parkinson's at parkinson.org/veterans. On this page is an FAQ guide that provides an overview of Parkinson's and VA resources, benefits and eligibility, and access to care. We are honored to support all of you on your Parkinson's journey. In addition to veterans webinars, we offer weekly webinars through PD Health and Home. Join us for Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. These webinars are live and recorded so you can watch them at your convenience. All right, now without further ado, we are going to get on with today's exciting program. First up, I would like to introduce Dr. Hillary Olson, who is with the Minneapolis VA. Hillary is a physical therapist and is here today to share with you more about the services that they provide. So thank you so much, Hillary, for joining us, and I'll invite you to join us on camera.
All right. Thank you, everyone, for joining. I'll just go ahead and just give a little bit of background just about me. As Annie stated, I am a physical therapist. I've actually worked at the Minneapolis VA healthcare system for the past 16 years. Primarily in the area of neurologic physical therapy, so brain injury, stroke, movement disorders, and Parkinson's disease. I started working with the Parkinson's population probably about 6 years ago, more consistently. And then about 2 years ago, I moved into a half-time administrative role where I serve as the program coordinator for our Parkinson's disease and movement disorders program at the Minneapolis VA. So I am here today to talk to you a little bit about kind of our program overview. And then I'll hand it over to Dr. Scott Lewis from neurology, who is one of our movement disorders neurologists, who will talk a little bit more about surgical options for patients with Parkinson's disease. And then Dr. Bob McGovern will join us at the end, and we'll talk more about the surgical process. And after each speaker, we'll have a few minutes to do some dedicated question and answer for that individual speaker. So if you do have questions, please feel free to enter them into the chat. So many of you may know or you may not know, but there are over 110,000 veterans in the United States that are living with Parkinson's disease. Some of those of you may be present on the call today, or you may know someone or a veteran with Parkinson's disease. So that is why we are here today. And I also just wanted to make a note that the Parkinson's Foundation and the VA healthcare system have a established partnership, which is why we're able to bring some of these talks and webinars and different services to all of you. So we were definitely grateful for the resources and the partnership between VA and Parkinson's Foundation. I have no financial or other disclosures. So I'd like to just provide a little bit of background to kind of set up Dr. Lewis and Dr. McGovern, just kind of give a sense of kind of the big picture and why some of the situations are how they are and things developed more recently regarding surgical options within the VA. So some of you may have heard of what we like to refer to as the PADRAC sites. If you're familiar with VA and the military as a whole, you know that we like to use acronyms. So PADRAC stands for Parkinson's Disease Research, Education, and Clinical Centers. So these are the VA's established centers of excellence for Parkinson's disease. These were designated back in 2001. So it's been a number of years since the designation was given to these sites. And basically, they're kind of a place where there's different types of specialties related to Parkinson's disease care. They have a clinical aspect, they have a research aspect, and they provide education. And they also offer specialized services such as deep brain stimulation, which we'll hear about today. Of note is that there are 6 of these centers throughout the United States, but as you can see on the map here, they're designated by the red dots. They are primarily located on the East and West Coast. Previously, Minneapolis has, or actually still is serving, the Minneapolis VA is serving as what we call a consortium site, which means that we have some specialty services for those veterans with Parkinson's disease, but if veterans are desiring additional specialty services such as deep brain stimulation, they would have to travel to one of the PADRAC sites to receive those services. And our veteran population within what we call kind of our region, which is VISN 23, our individual veterans were having to travel to the San Francisco VA to receive deep brain stimulation, which is kind of far away if you live in the Midwest. So you can kind of see here, VISN is just another acronym. It stands for Veterans Integrated Service Network. So in the upper Midwest here, consisting of Minnesota and Western Wisconsin, North and South Dakota, Nebraska, and Iowa. So what we were noticing, really, one of the things that's been more recognized more recently is just the rise in the prevalence of Parkinson's disease. So the ultimate number of cases, number of individuals living with Parkinson's disease has actually doubled from 1990 to 2015, as you can see in the chart here. And then it's actually expected to double again from 2015 to 2040. So essentially what that means is that Parkinson's disease isn't going away. We know that our veterans, especially our Vietnam era veterans that have had exposure to Agent Orange and other things of that nature, do have a higher incidence of Parkinson's disease. So it is important that we are able to serve all of you that have Parkinson's disease or your loved ones that have Parkinson's disease, which is part of the reason why we have expanded our services here at the Minneapolis VA. So even just a few short years ago, this is kind of a good depiction of kind of how our services were offered for individuals with Parkinson's disease. Primarily, care is managed by a neurologist, and this is one of our movement disorders neurologists, Dr. Lewis. So he would kind of work with the veteran on medication management if needed, or if was interested in deep brain stimulation, he would facilitate that process. And then we had kind of in other areas, maybe occasional referrals to physical therapy, or speech therapy if some needs maybe were coming up with those veterans. However, really up until more recently, a lot of times when veterans would be referred to different therapies, it would be later on in the disease process when more impairments or functional limitations were more apparent. And what we now know is that we can really start to change or modulate the disease progression with some therapeutic interventions such as exercise. So really an earlier referral to physical therapy and some of our other rehab services has been and will continue to be very, very important for those individuals. So as you can see, just as this illustration depicts, various people were just kind of managing care and doing their own thing, working towards goals for the veteran and with the veteran, but we were all kind of functioning separately. And then a few years ago, some of us decided to start to come together, kind of just informally meeting and discussing different patient cases, seeing how we could really try to collaborate in order to best meet the veterans' needs. And then also Dr. Bob McGovern came to the Minneapolis VA and had some interest and experience with deep brain stimulation and also with some research aspects of the Parkinson's population. So began to join some of our informal meetings as well. So that was kind of where we started. I like the little cartoon here because it's pretty telling. Our left hand doesn't know what our right hand is doing, so we're only interviewing ambidextrous candidates. So that's a good representation of 2019 and sort of the earlier care for our veterans with Parkinson's disease. And I'd like to just add to that, I think this model of care, it's not necessarily bad. It's just not our best that we can do. I think it tends to be a little bit more siloed. Rehab services are potentially doing what they're doing. Neurology is doing what they're doing, maybe some therapies here and there, but you're not necessarily having a comprehensive team approach and really working towards the veterans' goals. So that led to us recognizing that and applying for some funding through that VISN, as I mentioned, kind of the region, in order to enhance our services for our Parkinson's and movement disorders population. So our goals were to be able to bring a DBS or a deep brain stimulation center to Minneapolis in order to be able to provide this service in the Midwest so that veterans would not have to travel to San Francisco or other VAs to be considered for deep brain stimulation. Therefore, reducing the travel burden and also the financial burden of having to travel a far distance. And also we really wanted to be able to grow not just our DBS surgery aspects, but just our comprehensive care through rehab medicine or rehab and neurology across the VISN. So not just within the Minneapolis VA healthcare system, but really for those veterans in kind of our 5-state area. And as I mentioned before, the rationale for this is really that we didn't have a lot of comprehensive programming. So really being able to offer more things, knowing that we're going to continue to see the incidence of veterans with Parkinson's disease rise each year. The mission of our team and our program is to be able to provide passionate care that's innovative and informed by evidence through this multidisciplinary team. And really what we want is our veterans to be able to lead their most fulfilling life, even though they have this neuroprogressive disease process. Our team strives on establishing relationships and rapport with our veterans and their loved ones. And really our vision is to continue that compassionate relationship so that the veteran can lead their most fulfilling life in the highest level of independence possible, no matter what stage of the disease. This is a depiction of the care model that we embrace at the Minneapolis VA. So we like to think of a shared care model between primarily neurology and neuro rehab or rehab medicine, and then consultating with neurosurgery as needed and as indicated. So we can think about our neurology counterparts or neurologists as those that are helping to diagnose our movement disorders like Parkinson's disease, and they're going to provide lifelong medical management. They also help with deep brain stimulation programming if that's something that is indicated. From a neuro rehab or a rehabilitation standpoint, our providers there will help with kind of lifelong rehab management, which includes referring to specialized therapies like PT, OT, and speech, and then other ancillary services like social work, recreation therapy, caregiver support, etc. And what we've found by embracing this shared care model is that really our veterans then are getting the best care. They also have really good access to a variety of rehab programs, and their team is consistently talking and on the same page about their care needs. So this is a depiction of our team currently at the Minneapolis VA, circa 2022. We do have 10 dedicated full-time staff to our program, and then we have a handful of either part-time or sort of ancillary team members as well. So we embrace, as I mentioned, a multidisciplinary team that includes rehab medicine, and that can include a rehab medicine provider, which you may have also heard as a physiatrist. So that is our Dr. Kusar or our nurse practitioner, Lori Kubish. And then we also have our neurology counterparts, movement disorders neurologist, Dr. Lewis, who you'll hear from after me, and Dr. Lauren Schrock. And then we have a variety of therapists from speech, OT, and physical therapy, as well as psychology and neuropsychology staff and nurse case managers. So with this special funding that we received a couple of years ago, our target populations were Parkinson's disease and also essential tremor. You can see also that we're serving individuals that have other related conditions, some of which may be present on the call today, some that we refer to as Parkinsonism, which can include the listed diagnoses here. Someone usually when they're coming into our program, or typically even your local VA, usually you'll see a neurologist to get your initial diagnosis. Within the Minneapolis VA healthcare system, our neurology counterparts are the ones that refer to our rehab medicine providers to start to access some of those therapy services. And then other providers within our rehab department can also send a referral to our rehab medicine providers. And then just briefly, I'd like to, you're going to hear in a little bit more about deep brain stimulation. As I mentioned, that is a service that we offer through the Minneapolis VA now. So if you are residing within the VISN 23 catchment area, this is something that you can speak to your local neurologist about. We have partnered and have established relationships with the neurologists at each of the other VA sites within VISN 23. So I won't go into too many details about how to get connected, but the bottom line is that you should speak with your neurologist if you're interested in both the specialty Parkinson's disease services, but also if you're interested in deep brain stimulation. Really, your local neurologist is going to be the one that will place a interfacility consult to the Minneapolis VA, and that initiates or starts the workup process. You'll hear a little bit more about this. I won't go into great detail. I believe Dr. Lewis and Dr. McGovern will mention some of these things, but there's just a few considerations to keep in mind if you are interested in pursuing deep brain stimulation through the Minneapolis VA. These are some of the things that we want to consider. Thinking about traveling to the Minneapolis VA, that is something that would need to occur if you are interested in that. And also that you've had a documented trial of appropriate medications that you can work with your neurologist on. But like I said, I'll let Dr. Lewis go into more detail about that. Other things to consider if you're interested in these types of services is just that you have some way to do a telehealth appointment through the VA system. And that just so you know that the first appointment is really just an education session with one of our nurses, and they provide additional information and then kind of talk with you more about if you would like to continue to pursue the workup process. So at this time, if there are any specific questions for me, I'm happy to take them. Otherwise, we'll transition to Dr. Lewis, who will tell us more about surgical options for Parkinson's disease.
I'd like to thank everyone for coming today. What turned out to be a snowy day in Minneapolis here. The title of our talk today will be Veterans and Parkinson's Surgical Options. We'd also like to thank the Parkinson Foundation for sponsoring the talk today. My name is Scott Lewis. I'm a physician at the Minneapolis VA Medical Center. Specialize in neurology and subspecialize in movement disorders. I've also been working in the deep brain stimulation program here for approaching about 10 years now. I've been at the Minneapolis VA for a little over 20 years. I also work in an area called the Brain Sciences Center here at the Minneapolis VA. That's a research center in which we are studying Parkinson's disease as well, and it was initiated by the American Legion and the American Legion Auxiliary in conjunction with the University of Minnesota. I also am affiliated with the University of Minnesota in the Department of Neurology. They also have a very active deep brain stimulation program as well, which provides us additional information and resources. I too have no disclosures to report, no relationships with companies or conflicts of interest. I want to start out with what the prime objectives are of our presentation today. Participants will learn how Parkinson's disease symptoms may change over time and explore surgical options to help manage symptoms. Participants will also learn about the workup process for consideration of Deep Brain Stimulator Surgery, which we'll abbreviate as DBS, now available at the Minneapolis VA. Deep brain stimulation itself has been around now for quite some time. It was first approved by the FDA for treatment of essential tremor in 1997. It became approved for Parkinson's disease in 2002. So it's now been around for about 20 years, though experimentally and in research projects, even considerably more. It has been approved since then for other disorders as well. It was approved for dystonia in 2003. Dystonia is more of a fixed muscular posture that can occur in a couple of disorders, including Parkinson's disease. It was approved for obsessive compulsive disorder in 2009. It's also now been approved for epilepsy in 2018. Additional research activities are underway, looking at other disorders that deep brain stimulation may provide benefit to, and so this list will likely expand. I think, for me, the takeaway point from this is that deep brain stimulation is now an established therapy. It is no longer experimental, although we continue to learn new things about it. And it's been being used now for decades. Before we get too much into DBS, I'm often asked what are some of the alternatives to deep brain stimulation. Obviously, deep brain stimulation is a brain surgery. And people ask, well, what else could be done? And there are other techniques. The first group I kind of group under what I call ablative procedures. And what I mean by that is that before DBS was available, the type of surgery to work on the symptoms of Parkinson's disease involved putting a probe into one specific area of the brain, inducing a small lesion, in effect a stroke, removing the probe, and then reassessing the symptoms. It was found that if the lesion was in the correct area, tremor could be suppressed and other symptoms could be improved. When deep brain stimulation came along, it allowed the, in effect, the lesion not to be made and to allow adjustments after the surgery. So the ablative procedures kind of fell by the wayside. However, over time, of course, some people either don't want to have the brain surgery or the medical risk of the brain surgery would be too high. So not only has the original procedure, which is a second line, the thalamotomy and pallidotomy, named after the areas of the brain that are involved, continued, but there are two now that would be considered non-surgical procedures. One is called focused ultrasound. In that procedure, what is done is they use ultrasonic waves under MRI guidance to, in effect, cause a small lesion in the brain in the same area in which we put the probe. They monitor the effect of that lesion while they're doing the procedure to try to maximize the results. One potential downside, of course, is that when you make a lesion in the brain, there's no ability to adjust it afterwards. So the effect of the procedure is the effect you are left with. So if the lesion is not in the correct area or is a little bit off, it cannot be changed. There also is some concern about doing a lesion on both sides of the brain. So right now, focused ultrasound is approved for just one side of the brain and specifically approved for Parkinson tremor. So if a person has other Parkinson's disease that are disabling in terms of balance or other types of movements, would not be a procedure that would be the first choice. The pallidotomy or the lesion one that I referred to before is still being done, again, for individuals who could not tolerate the implanted hardware of the deep brain stimulation. Finally, I wanted to bring up gamma knife therapy too. It's conceptually very similar to focused ultrasound, except instead of using ultrasonic waves, they use radiation or gamma radiation to, again, cause a small lesion in the part of the brain that would help treat some of the symptoms. All of these are potentially available, though through this VA, they'd be through community care and neighboring facilities. Each one of them does have some concerns that make them probably a secondary choice, with DBS remaining the primary therapy of choice. There's one other, not necessarily surgical procedure, but one other more advanced treatment procedure in Parkinson's disease, and this is DUOPA. What this is the Parkinson's medication of carbidopa-levodopa, but it's put into a gel suspension. And it's infused directly into the stomach, or specifically the intestine. The intent of it is to provide a more even, in this case, constant administration of medication to help reduce fluctuations that people experience in Parkinson's disease. The procedure itself requires putting a thin tube through the stomach wall into part of the intestine, and that tube does have to remain there. This tube is then connected externally to a pack that has a cassette, which has the medication in it. The medication flow rate can be adjusted. The medication can be adjusted to kind of give a bolus, much like you do if you took a pill. It provides a very even flow over the day. So for people with fluctuations who would not be a good candidate for DBS, this would be an additional option. Some of the downsides can be, of course, you do have to take care of the fact that this is an intestinal infusion and the tube going into the stomach wall. The cassettes themselves, the medication has to be refrigerated, so it requires a little extra attention. The infusions themselves can be used up to 16 hours per day, so there's still an 8-hour gap that we usually have to bridge with medications potentially as well. And then, of course, there's a cassette that you have to wear while the thing is being infused. But again, if you're experiencing fluctuations in symptoms, this is a therapy that may very well help address that by providing a very continuous flow of medication. The other thing I should add here too is that since it bypasses the stomach by going directly into the intestine, there are thoughts that it might provide more steady absorption. There's some thought in Parkinson's disease that how fast the medication moves through the stomach is influencing fluctuations in how the medication is absorbed and therefore in symptoms. So this is another route that might bypass that particular concern. Going back to deep brain stimulation, we talked about the other procedures, so why would we select this as our first choice? Well, first, it can be put on both sides of the brain, so you can treat the symptoms on both sides of the body. Once the device is placed, afterwards, you can program it. In other words, you can change the amount of stimulation, you can change the location of stimulation, you can potentially turn the device off. There's flexibility afterwards. So as time goes on and perhaps symptoms changes, you can reprogram and readjust as necessary. So there's certainly more flexibility. Turning it off is a definite advantage since one, it allows more control over the situation. And for some individuals, which I'll mention like with essential tremor, it can be turned off at night and prolong the battery. The other thing is that with all the companies that make this device, you're provided with a programmer to take home. And what that is a small device. Nowadays, they look pretty much like a phone. And they allow the person to not only turn the device on and off, but also to monitor the battery and also to adjust the device within parameters we set up in clinic. So much like having medication at home that you can take as needed, you now have a programmer that can be, the parameters of which can be set as needed. And so you do have this kind of control to both sides of the body. So when would one might consider DBS? It's not a distinct line. Basically, it's when optical medical management does not adequately control symptoms. And that can vary person to person. So if the tremor is a primary concern and you're not being able to control the tremor, but you're able to get control of other symptoms, one could still consider DBS because of the tremor. If on other symptoms such as gait, balance, which we'll talk about, or stiffness are not being controlled, then DBS could be considered. I think the possibility of DBS also comes up when medication use is becoming more frequent, when the doses are becoming higher, and when you're having to take different types of medication. Since all of those be indications that we're trying different strategies to get better control over the course of the day. But at what point in time, you know, the threshold gets crossed when you want to consider DBS is kind of a discussion between the neurologist and the patient as to when the proper time is. Although I do think that when medications are becoming more frequent and we're having more trouble controlling the symptoms, we would certainly begin the discussions about DBS and what it might be able to offer. The other thing to consider too is that sometimes the symptoms are being pretty well controlled, but they're being met with a lot of medication side effects. Those side effects prevent further medication adjustments from being performed, and the side effects themselves are now becoming a problem. DBS would be a possibility at that point to treat the symptoms that are being treated by the medications, and also hopefully to be able to reduce the medication and therefore reduce side effects. In the course of Parkinson's disease, at what point is this considered? Usually people have had Parkinson's disease for years at that point. So it's considered probably more to the mid or later stages of the person's disease course. I wanted to go over Parkinson's disease in more specific detail, since it really goes into what the operation can provide. The cardinal or classic features of Parkinson's disease are bradykinesia, which are slow and small movements. They can be manifested as reduced blinking, less facial expression, less gesturing, a softer voice or difficulty swallowing. People may have trouble getting up from lower positions, like from bed or a chair or couch. Their steps might be reduced, they might shuffle. They may not swing their arms as much when they walk, and they may have trouble moving, which is freezing. They will have a tremor. This is called a resting tremor, in that if the person's hand is in their lap or hanging at their side, the hand will start to shake. It's called a pill rolling tremor because the way the hand shakes looks somewhat like the person's rolling a pill between the thumb and fingers. This is contrasted to other kinds of tremors, like an essential tremor, where the tremor occurs when the person's trying to do something. A Parkinson tremor will usually begin just in one hand, but later can involve both hands. An essential tremor will generally occur in both hands at onset. The other thing with a Parkinson tremor is that, in general, it will be when the hand is relaxed, and when the person picks up the hand, the tremor, at least temporarily, goes away. The essential tremor is the opposite, whereby there's no tremor at rest, but when they pick up their hands, the tremor will start. Another feature of Parkinson's disease is the rigidity or the stiffness. So people might have described having difficulty moving, difficulty initiating movement, generally feeling stiff. And finally, there are the postural changes. A person may have more trouble with balance. They may have falls. When they walk, they tend to walk with a bit of a stooped forward posture with shorter steps. Now, these are the classical features of Parkinson's, but there are a number of other symptoms too. And we kind of group these under what we call non-motor symptoms, because all the other symptoms refer to movement. Parkinson's disease itself affects many parts of the nervous system. These other symptoms, or the non-motor symptoms, can often predate the symptoms we described before. So these symptoms can be fatigue, difficulty with smell or anosmia, sleep changes, changes in dream enactment, constipation, changes in urinary function, sexual dysfunction, anxiety, depression, passiveness. The person may have some complaints of memory in certain ways. Maybe compulsive behavior, so that tends to be more with medication use. They may have hallucinations, again, more with medication use. But these symptoms can be as concerning, as disabling as any of the other symptoms, and we try to do our best to pay attention to each one of them. I wanted to take a short break here to just kind of describe the service connection for Parkinson's disease. There's two specific periods of service. One is the Vietnam era. People or veterans who've been diagnosed with Parkinson's disease who are in country or on the inland waterways between 1962 and 1975 are presumed exposed to Agent Orange or other herbicides and are eligible for service connection. The other group is from Camp Lejeune. I've been seeing their ads on TV lately. For individuals who served at that camp in North Carolina between 1953 and 1987 for the first 30 days, if they're diagnosed with Parkinson's disease, there's again a service connection. This is related to contamination in the well water. So if you had any of these periods of service and you've been diagnosed with Parkinson's disease, definitely contact your Veterans Service Officer and take advantage of your service connection. So we've kind of gone over the symptoms of Parkinson's disease. So one of those symptoms would be improved by surgery. Our general rule of thumb is that the symptoms that are improved by drug therapy are improved with surgery. So if the medication helps a symptom you're experiencing, such as tremor or slowness, we would expect the surgery to help as well. So the surgery can potentially help tremor. It can help the slowness of movement or bradykinesia. It can help the stiffness or rigidity. It can help the motor fluctuation where people feel very good in an on state. They're able to move, they're able to function, versus the off state when the tremor comes back, the slowness comes back, and they have more difficulty with movement. It can also help the dyskinesias. The dyskinesias occur when the medication is at a higher point and they start getting a lot of extra movement and look very restless. Not everyone has had the opportunity to observe him recently, but Michael J. Fox has tended to be one of my examples of an individual who often appears on his interviews while having dyskinesias. Each of these symptoms can potentially be helped with surgery. I want to have one slide that kind of emphasizes one particular symptom in particular. The Parkinson tremor, of course, can be helped by medication, but sometimes it doesn't respond as well to medication. They never really find the right dose to really suppress it adequately. Even in that situation, deep brain stimulation surgery will help the tremor. Now, if the person's problem is stiffness or slowness to movements and the medication has no effect on it, we would not expect the surgery to help that symptom. But tremor is the exception. If the medication is not working, we would still expect the surgery to help. So what symptoms are not improved by surgery? Well, first, it's important to point out that surgery is not a cure. Parkinson's disease is a progressive disorder and will continue to advance. Should interject here that the rate of progression varies across individuals a lot. Each individual person with Parkinson's disease has their own course and actually has their own constellation of symptoms. Not everyone with Parkinson's disease will have a tremor. Not everyone with Parkinson's disease will have problems with falls and balance. It's very individualized. Symptoms that are not improved at the peak dose of medication would not be expected to be helped by surgery, with the exception being tremor. So if the person's gotten to the point where their medication seems to be otherwise working, but they're trying to walk and get stuck briefly, that quick freezing, we would not expect, unfortunately, the surgery to help that. Cognitive and psychiatric symptoms. If a person is complaining about confusion or difficulty in thinking, if they're being bothered by anxiety or depression, the surgery will not help that symptom. Speech and swallowing difficulty. That too, unfortunately, is not helped by surgery. And finally, gait and balance. In general, we state that is not helped by surgery. One possible exception is that if the problem the person is having with gait and balance is occurring only during a period when their medication's at a low point and they're having their off symptoms, and these symptoms clearly respond to the medication being administered, the surgery might help that. But if the person's gait problems or balance problems are kind of occurring throughout the day, don't seem to be related to medication effect or timing, then unfortunately the surgery would not be expected to help that particular symptom. I will add that they are actively involved in research projects looking at different ways to try to address that particular symptom in Parkinson's disease. I often get asked if the medication will change after surgery. Overall, the answer is yes, it would be reduced. I think there's a lot of variability in that. I think that some people I've seen remain on similar amounts of medication. Maybe the distribution of medications changed. I have met a few people that were able to make pretty drastic reductions in medications following surgery as well. I think the general belief is that, a reduction of maybe 20 or 30% is reasonable after surgery. This reduction may also help any side effects related to medication. As time goes on, medications continue to be part of the management profile and will still be used despite being on deep brain stimulation. I kind of think of the two approaches as complementary, that deep brain stimulation provides treatment in its way. Medications can also provide additional treatment as well, and often they'll be used in tandem. Well, our focus today is on Parkinson's disease, but I want to just bring up briefly that deep brain stimulation is also performed here at Minneapolis VA for other disorders. A big one is essential tremor that I described earlier. Individuals with that have shaking of the hands when they're trying to do something. So if they're trying to write, if they're trying to do mechanical work, if they're trying to do woodworking, a tremor will occur in the hands that interfere. Often they might have a head tremor as well, but not everyone does. Individuals with essential tremor sometimes do complain about balance as well. Deep brain stimulation is very effective at treating the tremor of essential tremor. It would not improve the balance problems, however. Another disorder is dystonia, which is the fixed muscular posture that can occur for a variety of reasons. But that too has responded well to deep brain stimulation and remains an option for that disorder. So once you've kind of reached the point where deep brain stimulation is getting discussed, what do you do then? Well, the first step is to meet with a neurologist who specializes in movement disorders and is experienced in treating people with Parkinson's disease or essential tremor, to kind of consider where you are in the course of the disorder, how the medications that you use, are there other medication options, and to begin the discussion of whether deep brain stimulation would be appropriate. This will involve, providing information. The Parkinson's Foundation has a guide regarding this that we use. It can involve talking to other veterans or other individuals who've had the procedure. I kind of view it as a first assessment and information exchange session. If the decision is made to proceed forward, we will then start doing additional assessments in preparation of consideration for the surgery. The individual will meet with the neurosurgeon to review it from the surgical perspective. We will have the individual go to a neuropsychologist. They will do more extensive memory testing, which will also involve assessments of mood as well. We do this because it's part of the benefit risk assessment of proceeding with the surgery. A brain MRI will be performed. We kind of have our own way of doing brain MRIs, basically getting more specific images, more specific detail for the surgeon to make a decision regarding targeting of the surgery and the risk of the surgery. We'll also have a session where the person will come in and we'll record their exam. And by that, I mean we actually video record it. So in terms of Parkinson's disease, we have to have the initial part of the exam when people are off their medication. So we usually have them hold it sometime the night before so that there's at least 12 hours until the first appointment the next morning, when they will come in and we'll go through their examination while recording it. The person will then take a dose of the medication, we'll wait an hour, and then we'll repeat the same exam. We'll do rating scales on each of those two exams for comparison. The importance of this is it determines, how effective the medication is for the symptoms, and specifically what symptoms are being affected by the medication. And so if we see a nice response to the medication, that would indicate that surgery would be a reasonable consideration. If we see a less effective response to the medication, but it's mainly related to the tremor scores, surgery remains a consideration. However, if we do an examination and the person has a lot of difficulties that don't respond well to medication, then a surgery would not be expected to be helpful. We'll also involve early on visits with speech, occupational, and physical therapy, not only for part of the standard of care just in treating the disorder, but also begin the various assessments and rating scales that will help us assess surgical risk and the outcome of the surgery, how well it did, and how things have changed. Those become part of the evaluation too. The pre-surgical evaluation will often disclose other things we need to pay attention to. So this is still surgery, so there may be other medical issues that may be optimized before we pursue surgery. In our population, adequate diabetic control is very important, as diabetes can raise the risk of infection with the implanted hardware of the DBS system. The pre-assessment, including the neuropsychological assessment, may disclose problems with anxiety or depression that we need to manage prior to the surgery, given the potential effect on surgery on behavioral issues, as well as the change in medications that may result. Dr. Olson mentioned too the need for social support. That's a big part of our pre-surgical evaluation, since there are a number of visits here. A lot of information is being given. Post-operatively, there is additional visits and management, and there are follow-up visits to continue to work with the implant. So the social support, someone to kind of be another set of ears to keep track of things, someone who can learn the basics to kind of help the patient adjust to the new system, and things like how the home programmer works, and making sure they get to appointments when their medications are off and they need a driver. All these things necessitate having a good support system. For me, I always thought the biggest question on the pre-surgical evaluation is, what does the patient want to improve? We kind of went over what symptoms can improve and what situations they can improve, but it always comes down to what you want to improve. So, if you tell me that the tremor is the biggest thing, we've already discussed that the surgery can be very good for that. If you tell me that you want to improve your memory, the surgery is not good for that. So, you can easily have a situation where what I think will be really helped by the surgery is not of great concern to you, and therefore we have to have that discussion about what it is you want to improve, and is the surgery going to do that or not, or what's the likelihood. When we've got all this done, we have something called a consensus conference. What this does is we get everyone involved who's been part of the evaluation, neurology, neurosurgery, neuropsychology, therapists who've been part of the team, but we also make sure to include other neurologists who've not seen you before, who are kind of an independent party. What we do then is we present all the information that we've gathered. We can show the video recording to demonstrate your examination. And very much like a jury, we meet and we discuss all that information, what the risks and benefits are, and decide if this is a good idea to proceed. If it is not a good idea to proceed, we of course have a conversation about why, what alternative treatments we'll pursue, what other things we'll pursue. If there is, like, we think it's a good idea to proceed, but we really need to try this other thing first, like perhaps a different medication, we'll get better diabetic control, we'll make arrangements for that. If we have this conference and everything is good to go, we will simply conclude that surgery is a good idea, and we'll say that you're going to be offered the surgery. If you elect to proceed, then we'll start the ball rolling, and Dr. McGovern will take over from there. So I always like to describe this whole thing as a process. from seeing the neurologist to being lined up for surgery can often be several months. Gives time to ask questions, to explore other sources of information, to meet with other people who had the procedure. There's a lot of opportunities to get all your questions answered and everything lined up. I'll always tell people too that at any point in time during this, if you want to wait, that's fine. I've had a gentleman who pretty much made it to this point but said, no, I think I'm doing okay. I would like to wait. And we wait. And that's just fine. We can continue with the therapies we're already doing. If they decide to pursue surgery later on, some parts of this procedure may need to be repeated, but nevertheless, we'll go from there. So it's always a discussion. It's always a back and forth. It's always a consensus between ourselves and the patient. But if the consensus is to go ahead, we then refer to Dr. McGovern, and he will be taking over the rest of the talk. Thank you very much for your attention.
Thank you so much, Dr. Lewis. We're going to get to a couple of questions before we move on to Dr. McGovern. A few questions that came in during your presentation, and if any of these, we'll also be doing a final Q&A at the end with all of our presenters. So, Dr. Lewis, if you want to wait on any of these questions, just let me know.
Sure.
Okay, so the first question we got is, do you have any data in terms of how many veterans have actually received DBS surgery, nationally or locally?
I'll actually defer that question to Dr. McGovern. I know he has a slide at the end. He will go over our local numbers and how many have done it. Nationally, I have less of an idea. I think he would probably have a better idea than I do. Certainly, the number of veterans who've had DBS, I would imagine would be easily in the thousands now, since the procedure has been around since the early 90s. And actually, the San Francisco VA was very involved in the early trials of this device. So a lot of experience was out there. So okay. I'll defer a little bit of that question for Dr. McGovern.
Great. And I believe you kind of covered this, but we'll just maybe reinforce the message. So this individual is asking, does DBS eliminate the need for other medications like levodopa? And I think you kind of said that in most cases it does not. In most cases it does not. Yeah, I think it's always a complicated question because people can be on levodopa, they can be on like pramipexole, ropinirole, or amantadine. In certain cases, if a person's on a number of different medications, one or two of them may be discontinued and the other ones will be continued. I think though, in my experience, people will remain on levodopa, though not uncommonly at a reduced dose, in more exceptional circumstances at a much reduced dose. Great. Okay, and again, this is, I think, another one that you addressed, but maybe we'll just reinforce any key messages. Does DBS help with cognitive issues?
Well, we always like to kind of break that down and see what your cognitive issues are. I think that that's part of the neuropsychology testing, to kind of break down the way we think, because it's memory, it's language, it's visual spatial skills, it's a number of things. We kind of break down what it is. I think that I would say that the DBS does not help cognitive symptoms, unfortunately. I will put a little asterisk on that, if we think the cognitive symptoms have some relationship to the medications, and we're able to reduce the medications because of the DBS surgery, in that case, we might be able to help some of the cognitive issues like hallucinations are related to the medications. If we're able to reduce medications because of the surgery, we can then reduce the hallucinations. So it requires a little bit of a more detailed analysis, but I think that if somebody asked me, does it help cognitive issues like memory? I would say, unfortunately, not.
And I guess just to kind of piggyback on that response, have you seen sort of any cases where DBS has actually advanced cognitive decline?
Yeah, I think that that's why we do the neuropsychology evaluation as part of our pre-testing. I think what we find is that people who have had cognitive decline before the surgery, or having enough difficulty before the surgery, then doing the surgery, especially to both sides of the brain, can worsen the cognitive decline. So it's part of our pre-assessment of risk and why we do a lot of that memory testing.
That's great. Okay, and this is a longer question regarding service connection. So I know you discussed kind of Vietnam era, Camp Lejeune. This individual wanted to know about chronic occupational exposure to TCE, JP4 jet fuel, and then PFOA, PFAS in drinking water at other locations like the Charleston Air Force Base, which I guess has a higher drinking water than Camp Lejeune.
Yeah, I think that. Yeah, I guess I have two parts to that question. I think the service connection is ultimately decided by the Congress. So why they signed it to Agent Orange and specifically Camp Lejeune. As further information comes in or further research comes in, that of course may change, and I hope it would change. However, if a person has provided evidence of like the TCE exposure, which is a solvent, or exposure to another site in relation to the service, what my approach has been is like, well, what information can we gather? I'll take a look at the literature out there, see what's been published supporting the association between that exposure and Parkinson's, and then that itself can be submitted to the veteran service officer regarding whether there's a service connection or not. So if the evidence is being built and it's out there, there's the service connection can be broader than the Agent Orange or the Camp Lejeune, but it takes a little bit more work at this point.
Great, thank you. And then again, I know you covered this during the presentation, but could you just once again, just talk a little bit about what are the main symptoms that are improved or even disappear after DBS?
Disappear is a tall order. So I like to under promise and over deliver. I think that the symptoms that, as I said, kind of reiterate, the symptoms that respond well to medication are ones that we hope to reduce and improve. I think that tremor does very well with DBS. Reduction, I think, is very common. It was always a debate whether the reduction we achieve is enough for the person to be happy with. If we make an 80% reduction in tremor, is that a significant improvement in terms of your ability to function? That's kind of a back and forth question there too. But I think that tremor we can do very well with, and the symptoms of slowness to movements and stiffness to muscles, if they're medication responsive, we can do very well with as well. I think it kind of comes down to, again, a lot of that pre-surgical assessment, since these kind of questions kind of come down so specifically to the person in front of you. And so that's why I like to have a couple of visits with people. They get to know them, they get to know us, and we can start saying, okay, this specific symptom, this is what I see, this is what I think might happen, this is how much I think we might be able to improve it, since it's a gradation. It's unfortunately not an all or none. We seek to improve things, but it's unlikely we would eliminate a symptom.
Great, and again, you did cover this during your presentation, but again, just in case anybody missed it, what are some just good examples of when DBS alternatives, or should be considered? What are some kind of cases of when you'd recommend the Duopa or one of the other therapies as opposed to DBS?
Yeah, I think that it really comes down to what other medical conditions the person might have. I think if the person has respiratory diseases, that would make a general anesthetic a risk. If the person has diabetes that is difficult to control, that would make infection a risk. If they have something else where the surgical risk would be high for them, I would then consider these other procedures, since they could be done without, in case of focused ultrasound or gamma knife, they can be done without the surgery. I think certainly people would be interested in those for obvious reasons, since as an alternative to DBS, I think my view of that though is that they don't offer the flexibility or the ability to treat both sides of the body like DBS does. And so I still consider DBS to be the first choice. Then those would be alternative considerations. I tend to make the referrals when I think DBS, the surgical risk is too high. But I do have individuals who are interested in them because they simply don't want to pursue the surgical side of things. And I do try to help facilitate that as well.
Great. And I know you talked about kind of when the risk would be too high. What is an ideal age range, or, is there sort of at what point would you probably not consider DBS for someone just based on age alone?
I think that's changed over time. I think that in my consideration, it's not so much age as medical health. I think that certainly people in their 80s are being considered. I've not seen anybody that I would refer in their 90s. But I think it comes down to surgical risk and other medical conditions. If a person is otherwise healthy and active and they're 88, I would consider them a candidate.
That's great. Okay, we're just going to take one more question and then we'll get to more questions during our final Q&A after Dr. McGovern's presentation. Are there any financial benefits to considering some of those other surgical options like duopa or focused ultrasound instead of DBS?
Well, within the VA system, we do the DBS surgery here, we do the duopa here. So I think that in terms of cost to your care, I guess I'll have to refer a little bit of that to the business side of the office there. My understanding is that if it's a service connection for this disorder, the cost would be zero. So it'd be covered under the VA system for either procedure. But my family, the members of my family who are lawyers are ringing in my head saying, well, don't promise that for sure, double check. But it would be cost there. I think that I'm assuming that the financial considerations are cost of care. Okay. Yeah, I think that if the for the other alternative procedures like the focused ultrasound or gamma knife, those would have to be sent out to community care. Since they're sent from the VA, that should still be covered as well, but it does get a little bit more complicated there. But I'd kind of conclude not for someone seeing me in clinic, the first decision is, which of these procedures fits best with you? Which one do you want the best? And, after all that consideration, then we can think about, if there's any financial side of it. But I would actually, I think the first step is what's the best thing for you, period, and not think about money.
Absolutely. Okay. Well, I think that's a great place to end this portion. Thank you so much, Dr. Lewis. Now we are going to invite Dr. Robert McGovern, who is a neurosurgeon at the Minneapolis VA, to join us on camera. And Dr. McGovern is going to talk a bit more about the DBS process and what that looks like. So thank you so much again, Dr. Lewis, and we'll see you shortly for the final Q&A.
Fantastic.
All right. Thank you, Annie. Can you guys hear me? And you can see my screen, okay?
Yes, yep, looks good.
Okay, great. So, yeah, thank you to everyone for having all three of us here to give this talk. Thank you to the Parkinson's Foundation to let us give you some info about surgical options for veterans, specifically living with PD. And I will just try to build on what Scott and Hillary have talked about. There will be some kind of overlapping information, but it's always good to reinforce the main points. And yeah, please feel free to just put your questions in the chat so we can answer those. I am a neurosurgeon at the Minneapolis VA and at the University of Minnesota. I focus on, I'm a functional neurosurgeon, which means I focus on placing electrodes in the brain to treat different conditions, including Parkinson's disease, essential tremor, dystonia. I also do a lot of epilepsy surgery as well, with or without electrodes for that. But so today we're going to talk about what the surgical options are for veterans living with PD. And I know Scott mentioned some of the alternatives, and those exist. And so, but I'm really going to focus on deep brain stimulation, mainly because that's what we're doing here. And as Dr. Lewis mentioned, that does kind of remain the first choice, I think. So I don't have any disclosures. So what is deep brain stimulation? It is a procedure where there's a stimulator. Hold on, let me see if I can get my little laser pointer. Can you guys see this laser pointer moving around a little bit?
Yes, yeah, we can see it.
So DBS is a procedure where a stimulator that sits in your chest wall sends electrical pulses up a wire that is connected to a wire that then is implanted in a very specific part of your brain, and that stimulation helps to improve the symptoms of the disease. And that's true for whatever disease you place an electrode in for, regardless of what you're treating. Specifically for folks with Parkinson's, what we're trying to do with deep brain stimulation basically is maximize periods of good mobility, or you're on time when you're not having dyskinesias, like Scott mentioned. Dyskinesias are those kind of involuntary movements. You often see them, like he said, when Michael J. Fox is doing interviews and things like that. So we try to minimize medication-induced dyskinesias. We want to minimize periods of poor mobility, or your off time, what people usually call it, by controlling your symptoms, and tremor control. And so one of the ideas is, especially as the disease starts to progress, is folks have what we call these motor fluctuations, where earlier on in the disease process, maybe most of the time people spend with kind of what they feel like are mostly normal movements with their medication. They're on time, and maybe at the peak of their dosage, they get some dyskinesias and a little bit of off time. But then as things progress, the dyskinesia time increases, the off time increases, and the amount of on time where people feel relatively normal starts to decrease. And so one of the benefits of DBS is to smooth that motor function out, so you spend more time on. And oftentimes, like Dr. Lewis mentioned, that has the benefit of being able to reduce the medication, which also helps smooth out that motor function. So Scott mentioned this before again, but I'll just reiterate: the symptoms that respond well to DBS are the tremor, the stiffness in the muscles, the slowness of movements, and the small movements, as well as dyskinesias, which are those involuntary movements. And the symptoms that are not as responsive to DBS are speech, swallowing, handwriting, and then freezing and balance troubles. Now, again, the gait, the walking, and the balance troubles that people have, if that's traditionally what we say, that they don't respond to DBS. If, like Scott said, if the gait and the balance troubles are really during times that your medication isn't working, then those types of symptoms can improve. But again, we're looking for the symptoms that improve with medication for the most part. And then in addition to those kinds of symptoms, tremor and dyskinesias. So DBS is good for all of that. What is the most important thing in terms of making sure that DBS is successful? In my opinion, it's selecting the right patients. And how do we do that? The best way to do that is with the team that, kind of Hillary described before. So a multidisciplinary team. So if you're thinking about surgery, you should really have a team of people who basically are dedicated to your success. And so that's kind of what we've developed over the last 3 or 4 years at the Minneapolis VA here, where it's a multidisciplinary team. So there are neurologists who are experienced in movement disorders that do a comprehensive evaluation, that are able to maximize your medical treatment, and screen for folks who may have those Parkinsonism type syndromes that Hillary described and had listed on one of her slides there, because we know that folks with symptoms that may look like Parkinson's disease but are not Parkinson's disease, that are Parkinsonism, they will not really be good candidates for surgery. We need neuropsychologists who can help identify folks who have cognitive problems beforehand, and or other psychiatric comorbidities beforehand, to help manage that and to help us track how folks are doing cognitively after surgery. Because, I know Scott answered that question before, but that is a super important topic for folks. And I don't think there's really one pat answer that you can give to it. I can certainly give you examples of aspects related to cognition and DBS if folks are interested, but it's not a simple answer, really. And I think we don't exactly know what the how DBS affects cognition and vice versa. So it's very important, in my opinion, to have a rehab portion of your team. And that's not always the case at every place. Because as earlier mentioned, physical therapy, OT, speech, there is almost all of the therapy, rehab medicine, almost all of those disciplines really play a big role in both along the spectrum, along the entire journey, I guess, or the entire process for folks, pre-surgical, post-surgical, or not surgical at all. And so I think it's super important to have folks who are experienced in the therapies that we know work to improve folks' symptoms and potentially slow down the disease process even. You need neuroradiologists who can perform the appropriate imaging for targeting those very small areas of the brain that we're looking to target in DBS surgery. And then you notice I put neurosurgery at the bottom as the least important person, because all we have to do is just put it in the right spot. So so that's the easiest part compared to all that. When you think about all the things I just said, so I think it's a really it's important to have all these folks involved in your team. So again, Scott talked about this before. What's not addressed by DBS? I won't spend too much time on it. DBS is not a cure for PD, and it will not stop the progression of PD. It is a quality of life surgery aimed to improve the quality of your life by improving the symptoms that are caused by PD. And like we said, it does not address balance trouble, gait, speech, urinary problems, cognition. Again, with those kind of small exceptions that we talked about before in terms of gait and or balance. What are the targets that we are looking at in DBS? There are 3 targets generally for movement disorders. There's a region of the thalamus called the ventral intermediate portion of the thalamus. Usually this is really more for folks who have essential tremor, but occasionally we will target it for folks with PD for their tremor. And the other two targets that we more typically choose are called the subthalamic nucleus and the globus pallidus. Each of those targets they both work equally well in terms of improving your motor symptoms. There are slight differences between the two, which may cause us to choose one or the other target in your specific scenario. And as you go through the process, if you go through the process, we would basically kind of talk you through why we would choose one or the other. It's a little too detailed to get into for this talk, but I'm happy to talk more about it if people want. So just in terms of the nuts and bolts, I think people are interested in knowing kind of how this works and what is it, what does it entail? So what are the basic steps? So in general, the DBS system consists of a few different parts. One, which is the electrode or lead that's actually implanted into the area of the brain that affects the movement, that affects your movement. So this is the lead that goes into the brain. There's a burr hole cap that secures the lead in place. So this is kind of secured down to your skull, essentially, and the lead comes out through this little window here. And then it is secured with this, with the little cap on top here. Then the end of this lead is connected to an extension wire, and that wire is what runs down kind of the behind your ear to down your neck into your chest, and then the battery that sits in your chest that powers the system. And then the final part is there's a clinician programmer and a patient controller that basically communicates with the battery that's sitting in your chest via Bluetooth. And that's how your DBS clinician, like Dr. Lewis, will change your settings and see how they are affecting and hopefully improving your movements. So those are the components. Now, how is it actually implanted? If you asked probably 30 different neurosurgeons, you probably get 30 different ways that these are implanted. And so I can't tell you every way that folks do it, but I can tell you the general gist of it, and I'll tell you specifically how we do it and why. So there are two different ways of putting the electrode actually in, and one is using what's called a stereotactic frame, in which a frame is actually attached to your head with a liberal dose of numbing medicine all the way around. Then there's frameless surgery. Now, the frameless surgery doesn't mean that something still isn't attached to your head. Something is, but it's not the actual stereotactic frame. We use stereotactic frame in our practice because it's more accurate. And in my opinion, the most important thing, like I said on that slide before, the most important thing when it comes to a neurosurgeon, at least, is getting it in the right spot. And so you want to use the most accurate method available to you, in my opinion. So that's why we use a stereotactic frame. There are, it can also be done either awake or asleep. And so now what does awake mean? Awake does not mean that you're awake for the entire surgery. It means that we wake you up for the part that we need you awake. There are some places that do DBS surgery completely asleep, meaning you're under general anesthesia the entire time. There are advantages and disadvantages to each approach. I'm happy to expand on that if folks want, but I'll tell you that for the most part, while we have the capability of doing asleep surgery at the university, not necessarily at the VA right now, we do our surgeries for the most part awake. And that is because when you are able to wake somebody up during surgery, you can test if the electrode's in the right spot, basically. Now, it may look like it's in the right spot based on MRI or CT scans, whatever you want to use to localize your electrode, but we don't necessarily know that anatomy always correlates with the right spot for you. And so when we have the ability to wake you up during surgery. We can basically turn on the electrode and see if your tremor goes away or see if your movements get better and make sure you're not having any side effects, basically. The targets that we're talking about in your brain are on the order of a few millimeters long and a few millimeters wide. So if you're even just a millimeter off, you might not get much benefit. And so for the most part, we really perform the vast majority of our cases awake. And that is because we want to be able to know in the operating room that your stimulator is going to work and it's in the right spot. And again, awake surgery for the most part means you're asleep or sedated at the beginning and at the end, and then we wake you up in the middle for about an hour or so. I won't get into so much of the nitty-gritty in terms of unilateral versus bilateral. You can get, if you're a candidate for both sides, some folks will, or many folks will do both sides on the same day. Some folks will do one side on the same day and then have you come back and do the other side later. It's really just preference. And then in terms of the batteries, there's been a pretty accelerated movement in terms of technology improvement in the last 5 years or so, such that there are many more battery options available now. Rechargeable batteries last, 15 to 20 years, but they do have to be recharged every week or two for 30 to 60 minutes. Non-rechargeable batteries are bigger, they're bulkier, but you don't have to do anything. They just have to be replaced every 3 to 5 years generally. So it's really, that question is really more purely patient preference. What are the steps in doing DBS? The first step is really all done by me before you ever come in, and that is the imaging and planning. So basically you get an MRI beforehand, and I plan where I want to put the electrode based on the MRI. Then again, this is the way I do it. Everybody does it a little bit differently. But then I will see you on the day of surgery, place a stereotactic frame in the pre-op area, get a CAT scan with your head in the stereotactic frame, and then those images are all merged together. So if you think about the frame, it's basically like GPS for your brain. And in order for that GPS system to work, I need some pictures of that frame, of your head within that frame. So I can put the plan that I developed before on the MRI together with the CT scan. And basically that will spit out kind of XYZ coordinates for where exactly in that frame we need to target to get the electrode to the right spot. So we use, sophisticated imaging and software, which lets us target the exact spot in the brain that we want. And then during the surgery, we do this microelectrode recording, which this is the awake part of the surgery. So we actually will listen to the different areas of your brain. The areas of your brain will make kind of different sounds, and they will respond to movements of your arms or legs or face or mouth. And that lets us know kind of where we are in your brain and lets us kind of three-dimensionally map your brain to make sure that we are in the exact spot that we want to be. So that if we aren't, then we can move things around and get the electrode into the spot that we want. So that's basically, this portion of the surgery. We map the brain area we want with the microelectrodes. Then we put the electrode into the final spot. We test it during surgery to, like I talked about before, to make sure that A, you're not having any side effects, and B, that the electrode, when we turn it on, is doing what we want it to do, either making your tremors better or your movements, your stiffness. Those things we can test during the operation. So this is just an example of what that mapping, the microelectrode recording mapping sounds like. And basically what you want to listen to here is when Dr. Allman, one of our electrophysiologists, when he's moving the arm, you'll be able to kind of hear the brain cells respond to the movement of his arm. So you're going to hear some white noise kind of in the background, which is just the background noise of the brain, which sounds weird to say, but that's the truth. It kind of sounds like static on your radio. And so you'll hear that. And then when you see his arm move, you'll see that the cells respond to that. So let me see if I can get this to work. No, it's not working, of course. So you got a sense. I don't know why let me just see if I can get my PowerPoint to work better now. But you probably got a better sense with the finger movements, since I didn't want to. That video is a little bit long, so I didn't want to go the whole time. But you could see when he's basically tapping the fingers, you could kind of hear the cells responding. So again, that lets us really map the area of the brain that we want to be in by telling us that those areas are responsive to hand movement, arm movement, things like that. Because lots of times, obviously, if folks want better improvement with their tremor or they're focused on their arms or hands, we want to make sure that the electrode's in that area. So that's that portion of the surgery. Then we secure the lead with that cap like we talked about and fix it in place and then just close the incision. The second phase of surgery involves implanting the extension wires. So we implant the extension wires here, run it down to the chest, and then hook it up to the battery, which is placed in the chest. And before we leave the operating room, we make sure that all the connections are okay and that the stimulator will work as planned. This part is under general anesthesia and usually takes about an hour. It's much shorter. It's an outpatient surgery. Go home the same day. The prior surgery, the brain surgery portion of it, say about 95% of folks stay overnight one night and go home the next day. After the surgery, usually we do a wound check a couple of weeks afterwards. Dr. Lewis or whoever is doing your DBS programming will generally program about a month after surgery. And after that, there are regular adjustments pretty frequently in the first 3 to 6 months after surgery. Some folks, we usually wait about a month to turn it on because very frequently when just putting the electrode into that part of the brain will make some of your symptoms better, particularly the tremor may go away. And so it's difficult to program to know what settings are going to be best for you if you're not having your typical symptoms in that time frame after surgery. And then we replace the generator or battery when the battery power kind of runs out. And that's an outpatient procedure. It takes about 30 minutes. And again, that's usually every 3 to 5 years for those non-rechargeable devices. What's new? What's kind of happening in deep brain stimulation surgery? I won't belabor it too much, but I did mention that some of the, there is a lot of new technology that's coming out. One, probably the most important of which is this idea of directional stimulation or using segmented electrodes. And the idea is basically this: if you want stimulation in kind of this yellow area and not the blue area, in the past, when you turn on the electrode, you basically create kind of like a sphere of current. And if that sphere of current hits some of the blue area here, which is an area you don't want to hit because it's going to cause side effects, all you could really do before was turn it lower to make that sphere kind of smaller. And while that might get rid of some of the side effects, it also might reduce some of your benefit. And so some of the newer electrodes now are basically segmented into thirds, so you can kind of turn off one side of the electrode and turn on the other two sides, so you can theoretically maintain the benefit that you're getting from therapy and not get any side effects. And this is just kind of a video that shows that you can change the sphere into whatever shape you want. This is kind of like the traditional programming where you could either just make the sphere smaller or larger. But here you can kind of see you can shape it however you want, theoretically, into whatever shape you want. How do folks do who get DBS? What kind of improvements can you expect? There's a bunch of data on this since DBS has really been approved for basically 20 years and has been studied for probably 30 years or so now at this point. And so how people do has been well studied. And what we found basically is that the tremor, the stiffness, and the slow and small movements are what get better. If you measure these on a rating scale, which is what you'll get during that pre-surgical eval, it comes out to about 14 or 15 points, and on that rating scale. And I think that most folks with PD rate about a 4 to 5 point improvement as clinically meaningful. In other words, if you ask somebody what if they feel better, it takes about 4 or 5 points on that scale for them to say, okay, I feel better than I did before. The long-term data from those studies, that improvement's stable at least 3 years out when you look at the randomized controlled data, and I'm sure lasts longer than that for the vast majority of people. Now that improvement will probably start to decline over time as the disease progresses, but that is going to be different for everybody. Like I said, there are a couple of small differences in targets. And so the subthalamic nucleus target probably leads to a greater medication reduction, at least in the short term. Long term, it's a little less clear. And the globus pallidus target's probably better for folks who have very prominent dyskinesias, and it may have less cognitive or neuropsych comorbidity. The health-related quality improvements. So in other words, if you ask somebody how much their quality of life has improved after surgery, they will tell you that it improves. And again, that this somewhat diminishes over time as the disease progresses. What are the risks? Again, I don't want to go too far into the super details, but this is a quality of life surgery. This is not a cure, and it's not a life or death sort of surgery. So when you think about the risks, you really want to make sure they're as minimized as possible for this kind of surgery. So the main risk for DBS is really hemorrhage or bleeding, and it's about 1% per electrode. So if you get both sides done, it's probably about 2%. Now, not every episode of bleeding is the same. If there's a little bit of blood on the surface of your brain, that might count for towards that 1% that people cite from the clinical studies, but it's not going to be something that you notice. The risk of bleeding deeper within your brain is probably much lower, probably in the order of 0.1 or to 0.5%, 1 in 200 or lower, but it is not zero. And if you do have bleeding deep within your brain, then it would basically kind of look like a stroke, where you might be weak or numb on one side of your body. And so, basically, if you're thinking about the surgery, you have to be willing. What I tell folks is you have to be willing to accept a little bit of risk in order to get the benefit of this improvement in your quality of life. And as a surgeon, it's basically my responsibility to do everything I can to minimize that risk by looking at the MRI, looking at all your scans beforehand, and planning a trajectory that minimizes that risk, basically to as close to zero as I possibly can. The other risks are infection. You're going to have hardware implanted in your body. There's always a chance that it could get infected. Like Dr. Lewis mentioned, if you do have diabetes, you want to keep your A1C as low as possible to minimize that risk. There's always a possibility that hardware could not work or fracture or migrate. I think in the past that was probably much more common. I think now with the newer hardware, it's much more robust, much more resistant to that kind of stuff happening. Here specifically at the Minneapolis VA, we started, there's more than 75 veterans who have already DBS implanted and are managed by our movement disorder team. We started implanting folks November of last year. We had 13 scheduled cases in our first year and have done 8 of them. So, well, probably more than that now so far, with some reschedulings due to a variety of COVID complications. And we're planning for, to basically get up to about 2 implantations per month at our center, hopefully at a minimum. And that's kind of our plan here. Hillary already talked about this, so I won't go again too much into detail here, but if you are interested, if you live in our region, in that VISN 23 region, and you are interested in DBS, we will be able to do that here at the Minneapolis VA for you. You just have to talk to one of our neurologists, and you can ask your primary care to place that neurology consult or your neurologist to place a DBS consult. And then, as Hillary mentioned, our nurse case manager will call you to discuss it and eventually hopefully bring you out here and bring you through the workup that Dr. Lewis had mentioned before. So just some final thoughts. I think, obviously I'm a biased surgeon, so take it with a grain of salt, but I do think that DBS can really be a great option to improve motor symptoms, to improve your quality of life for veterans with PD, particularly with regards to tremor, dyskinesias, and medication losing its effectiveness, wearing off. And a true multidisciplinary approach really is the best way to serve veterans with PD. And if you're interested, then please get in touch with us. And all my contact info is there. The emails for our program coordinators are there. And thank you.
All right. Thank you so much, Dr. McGovern. Now we're going to bring our other presenters back on camera. It looks like we've only gotten a couple of additional questions, but I'd love to have all of you guys, weigh in if you have anything to contribute to these questions. And then please continue, if you're watching today, please continue to submit your questions through the Q&A icon at the bottom of your screen. So Dr. McGovern, going back to this question, I know that we kind of touched on earlier. I saw the stat about how many cases you guys have locally, but do you have any statistics in terms of the number of veterans nationally who have undergone the DBS procedure? I don't know if there are any stats around that.
I don't know that off the top of my head, but I would guess, like Scott mentioned, it's in the hundreds or thousands, I would presume, because like he said, the VA ran one of the original clinical trials, which had a couple hundred people in it alone. So I have to think it's more than 1,000. Yeah.
That's great, really helpful. And then this was a question, I think this person was referring to people with like a Parkinsonism or, some sort of condition that can kind of mimic Parkinson's, but has a different disease pathology. For those individuals, is DBS, still something that's recommended, or does it just really depend on the individual?
Yeah, I mean, Scott can probably answer this too, but I think for the most part, the answer to that would probably be no. But it depends on the individual, if, for example, somebody has a tremor that we think we could treat, then it might be something that could be treated. But those other diseases that are, Parkinsonism, generally we would not consider for DBS, I don't think.
Yeah, I would agree. I think that's certainly part of the initial evaluation process of Parkinsonism versus Parkinson's disease. We'll get a lot more information about that too in the testing I referred to when we hold the medication and then give the medication as well. But I think everyone's an individual, of course, and so depending on the symptom that is of concern, it's always worth asking the question and trying to figure it out.
Great. Okay. And then this person asked, Dr. McGovern, this is maybe for you. Can you tell us what a functional neurosurgeon is and how this specialty differs from other neurosurgeons who do DBS?
Yeah, I would say, a functional neurosurgeon is somebody basically who is dedicated and focused on doing DBS. It doesn't have to be DBS. What I would say is it's like everything else in medicine. It's kind of developed organically over time. For the most part, functional neurosurgeons have done dedicated training in the stereotactic or precise placement of electrodes in the brain to treat a variety of diseases. It doesn't have to be DBS, but that has to be one component of the training, basically. But functional neurosurgeons treat pain, they treat epilepsy, they treat movement disorders. And so it's not like I couldn't give you probably one specific definition, but it's a branch of neurosurgery that's focused on treating a subset of diseases like epilepsy, pain, movement disorders, and usually through the placement of electrodes in a precise way. That's what I'd say. But it can be ablative procedures, like Scott mentioned. A lot of functional neurosurgeons do ablative procedures, and that's part of the training too. So it's not necessarily limited to DBS, but it's focused on treating those diseases, I would say.
That's great. Okay, and I think this question was prompted by one of the other questions. How do you, and Dr. Lewis, this is probably for you, how do you differentiate between Parkinson's disease and Parkinsonism?
Well, I can start out that one a little bit here. I think that Parkinsonism I always think of as the broader category of symptoms that can include balance issues, gait issues, tremor. The most common disorder within Parkinsonism is Parkinson's disease, which has the classic features I referred to with the response to levodopa. What distinguishes Parkinsonism is usually other symptoms that would be considered atypical for Parkinson's disease. So it might be Parkinson features with very early cognitive and memory problems. It might be Parkinson's disease with very early hallucinations. It might be Parkinson's disease that very early on seems to symmetrically involve both sides of the body, which would be atypical for Parkinson's disease. It might be, again, Parkinson's symptoms with imaging findings like normal pressure hydrocephalus. So I always think, Parkinsonism is got some overlap in the symptoms with Parkinson's disease, but there are other symptoms or features that would be atypical for Parkinson's disease and distinguish it into one of these other categories.
I have a follow-up question, Dr. Lewis. Can you speak a little bit? I know sometimes when we're seeing individuals that have received a Parkinson's diagnosis, as their disease progresses or their symptoms change, then their diagnosis might change. Can you talk a little bit about, potentially to one of the other Parkinsonism, can you talk a little bit more about how the neurologist determines that diagnosis or how it might change?
Yeah, I think, well, I'll self-describe myself, I guess, here. We're very detailed people, and we try to put things in very particular orders. So for myself, I think when I first meet somebody, I might see symptoms that for me suggest Parkinson's disease, but I'm not quite sure. It doesn't seem quite typical yet, or something might seem a little bit atypical. So in my own mind, I kind of group that under Parkinsonism while I kind of figure things out. And, additional exam findings or additional tests might help me. Time might help me. Medications we try might give me more information too. So One category would be where I kind of start out saying, well, it's Parkinsonism. And as I get more information, I then settle on a specific thing within Parkinsonism, like Parkinson's disease. The other thing that can happen too is that for some individuals, like with Parkinson's disease, their course can change over time and they can have more trouble with memory and get a dementia diagnosis. This can go more into a Parkinson's disease with dementia, which is in some ways similar to Lewy body dementia as well. Sometimes it kind of evolves that way. But for me personally, I think it's more one of, I don't want to give a specific answer till I'm pretty confident I'm right. And so sometimes I'll say Parkinsonism until I know a bit more.
Right.
I can also sometimes add that, sometimes, it's hard to be 100% certain over time as well. So sometimes I do actually find myself entertaining an alternative diagnosis and treating accordingly as well.
That's great. And this question could probably be for really any of you. I know one question that we've gotten in the past is, does DBS sort of inhibit any type of exercise? One of the things that we encourage more than anything else almost is that our Parkinson's community should be exercising as much as possible. So what are your general recommendations for somebody who's undergone this procedure in terms of when to get back to the gym, or do they need to see a physical therapist before doing so? What are some of those recommendations?
I mean, from just like a general surgical perspective, I can give you that. I usually tell people that it will take, a month to 6 weeks for their wounds to heal up, and so we want that to happen before they, going back to kickboxing or whatever, but I still want them to be active really even from day one, basically post-op. So walking, exercise as much as you can without doing too much weight bearing stuff, too much, heavy lifting basically, but active exercise from day one is fine and encouraged, I would say, because it helps with the healing process. It helps them recover faster, all that stuff. So I wouldn't say there's really any contraindications. It's really just heavy lifting we kind of want people to stay away from.
And then I would
go ahead. I was just going to add too, I always kind of consider the whole point of a lot of these things is we want you to get out and enjoy things and do as much as you want to do and can do. There's always the very, unique precautions we kind of include into part of our evaluation. That, if you're a hunter, we don't put the implant on the side of the chest to brace your rifle. If you are a welder, there are some precautions on what kind of welding you can do afterwards. So there are some very specific situations, but I think in general, I don't think the DBS precludes much of anything. I think usually it comes down to more one of, I want to make sure that you're safe, and if there's a risk of falling, I always do have a few precautions that were in place already about certain activities, and I don't want people cleaning off their roofs or taking up some activity like that, but I don't want anybody to do that. So I think my attitude is get out and enjoy things.
And I'll just add a couple of points from a physical therapy perspective and kind of an exercise perspective. With our individuals with Parkinson's disease, we do complete pre and post DBS objective assessments, meaning that the measures that are recommended to be completed through our physical therapy neurologic counterparts is what we're using at the Minneapolis VA. So we can tell if, some things have been maybe changed or altered or worsened or gotten better after the surgery for whatever reason. So even if you're just a little bit less mobile and you're more deconditioned, maybe your cardiovascular endurance isn't as good post-surgery. So those are some things that we'll keep an eye on. The other thing I'll say is that it's very individual and individualized. So we make sure that we know our veterans with Parkinson's disease who are getting DBS, and we do a thorough assessment before they get it. And then we can closely monitor after surgery to make sure that they are at least keeping up with their baseline activity with maybe a few modifications of their existing exercise regimen. And then, if they need some additional or increased one-on-one therapy for whatever impairments they might have, or post-surgically, then we would see them for that as well.
And just one random thought, if you decide to engage in international travel, remember to bring your home programmer with you.
That's a good tip. Thank you. All right, especially now as people are going back out and doing more traveling, trying to kind of make up for lost time over the last couple of years. That's a good point. Okay, we'll just get to a few additional questions. One question is, and I know Dr. McGovern, you talked a lot about kind of lead placement and, how precise that process is in terms of the pre-planning and everything that's involved. But what happens if the stimulator leads are not placed correctly? Can they be fixed?
They can be fixed. From a neurosurgeon's perspective, that's pretty much like worst case scenario. So I don't like to think about that if it happens, but it can happen. And at that point, it really becomes a discussion, I think, between you, your neurosurgeon and your programming neurologist, or, programming NP or whoever does your programming. And you have to decide kind of what went wrong, why it's not in the right spot, what's not working, and what you want, kind of like Scott said during the original process, almost what you want to get out of the revision. Most of the time, if we can see that it's not in the right spot, and then you have a reason for it not working, and then we can move it, to get it in the right spot. But it can be revised. It's really not an ideal situation, but the leads can definitely be revised if they need to be.
And I know kind of we already talked about, the fact that, you can turn it on, turn it off, so, there are certainly ways that you can kind of manage it and really customize it to, make sure that person and that individual's quality of life is as good as it can be. And how much programming, and sort of if you could kind of again reiterate, the sort of the post-op timeline, how soon after having that initial surgery could someone expect to really feel better, really notice a major difference in terms of symptoms?
I guess I can start that one. As Dr. McGovern mentioned, there can be what we call a micro-lesioning effect, whereby simply placing the electrode in that part of the brain, you can notice benefit. So a person might notice less tremor immediately post-operatively. Now that effect is expected to wear off. And then we do the programming, which is typically 1 month after the last lead placement. So if they had one lead placement, it's a month later. If they had two leads, it's a month after the second lead. That gives enough time for that micro-lesion effect to kind of determine how much there's going to be, or if it wears off. And then we can start with the programming. So about 1 month later, we'll do that. As the brain recovers and as we work on the programming, sometimes a lot of the effect is in the first month or two that we can successfully program. There's often adjustments made. I usually think, I usually say at least over the first maybe 3, even 6 months. Now that's not a visit every month. It might be 1 month later, then 2 months after that, then 3 months after that, something on that scale. But then we kind of hit a kind of a baseline at that point where we kind of got a good idea what the electrodes will do. We got a good idea where the programming is. We kind of hit maximal benefit and things are looking good. And then we kind of can space it out a bit longer. I think if questions come up down the road, or if, as expected, things might change, progress, the program can be revisited and we can start the process over or adjust things on that well too. But in my own mind, I usually tell people that We kind of don't know the final complete result, maybe up to 6 months.
Great. And could you kind of talk a little bit more about sort of the school of thought in terms of when, ideally when somebody should, consider DBS? I mean, I know that there are some who consider this like, the very last treatment option, but then there are others who see it as more of an early interventional tool. So could you talk a little bit more about sort of the school of thought and general best practices around that?
Yeah, I think that's kind of an evolving topic. I think when it first started out, I think it was kind of considered one of the treatments you kind of consider after everything else has failed. And it certainly moved up in time that the benefit will be there earlier and might be better for the person earlier. I think, as I kind of alluded to, it's hard to draw a line. I think that certainly we would not consider unless the person's had Parkinson's disease for a number of years. And I think that after that, I think it kind of comes to a point where it's like, you're meeting regularly, you're discussing symptoms, and if you're finding that there are symptoms that you think might respond to DBS, and you're really having trouble controlling with medication, and they are bothering the person, I think that's certainly when you'd start the discussion or see if the person's heard about it, thought about it, what they think about it. So that could be after the person's had Parkinson's disease for only 6, 7 years. It could be after they've had Parkinson's disease for 12 years. It kind of where you hit that point where the symptoms are interfering with their enjoyment of life, and we think we can do something about it with DBS that we can't do with medication. So it's a bit of a sliding point deadline or so.
Okay, well, we have not gotten any additional questions in. So I know, one thing that we had kind of talked about earlier is, research that's going on. Could you guys talk a little bit more about any, research opportunities that are going on either through your center or, through another VA, related to surgical options like DBS?
Dr. McGovern, do you want to talk about any of your research?
Yeah. I can talk a little bit about mine. I think, like we mentioned, the gait and balance symptoms in PD are really difficult to treat and not very well treated for the most part with DBS. So I'm interested in those, and we have a bunch of studies going on here at the Minneapolis VA related to trying to figure out what are the factors in gait and balance that are important for folks with PD. What do folks with PD look like at home in terms of their gait and balance? So we send folks home with sensors to kind of study how they move around at home and how that's affected by DBS and not affected by DBS. And some things like that. We've also incorporated the use of sensors into the evaluation process to kind of look at how people look at the clinic versus how they look at home in terms of their gait and balance, with the idea that eventually hopefully we can figure out either new deep brain stimulation targets or a new stimulation paradigm that will improve folks' balance and gait. And those stimulation settings might be different for your tremor or your stiffness as compared to your gait and balance. So that's kind of stuff that we have going on or that's kind of stuff I have going on at the Minneapolis VA, at least.
I can do a quick plug of ours too. At the Brain Sciences Center, we're doing a study looking at impulsivity in Parkinson's disease. Some of the behavioral changes that occur leading people to gamble, spend, be more involved in hobbies, things of this nature, engaging in more risk behavior. We're looking at using magnetoencephalography, which is a brain imaging technique, looking at the pathways that are involved in that kind of determination and how the Parkinson medications play a role in that. So.
Thank you both. And then just one last study. This is a national study that VA is participating in. I am sharing a slide here, and I believe the link to potentially learn more about this study will be in the chat. But this is a study that is, we're recruiting individuals for, VA is recruiting nationally just to be able to, have some veterans provide information about themselves in order to basically accelerate research and also just improve health overall for everyone. So we're looking to get a diverse panel of individuals. If this is something that you're interested in, you can go to the website here, or you can call, and that will also be in the chat. And then I know that Parkinson's Foundation will also share a variety of resources, but if you're looking for more information specifically about some of the things that we talked about today, specifically in Minneapolis, we do have an up-to-date website. It features various resources, talks a little bit about both our neurologic rehab and neurosurgical programs that we offer through the Minneapolis VA. Also has a lot of different resources for individuals with movement disorders and also Parkinson's disease. So that can be a great resource if you're looking for kind of locally specific things. And then also the Parkinson's Disease Education Research and Clinical Center site is another good resource for information regarding veterans and Parkinson's disease, and resources available such as some of the service connection pieces that we talked about and some of the exposures. And then obviously Parkinson's Foundation as well has tons of great resources, has a really robust resource library. So I always encourage people, if you have a topic that you're interested in learning more about, to go check out parkinson.org and find their resource library, and you can just search the topic that you're interested in, and you will find a variety of really good informational handouts.
That's great. Well, thank you guys so much for your time today. Dr. Lewis, Dr. McGovern, and Dr. Olson, you guys provided so much information to our attendees. So thank you for being here. I'm just gonna go through a couple of quick housekeeping items before we let everybody go. So once again, we just want to thank our presenters, thank our attendees. I have certainly learned a lot today. Immediately following today's program, and I should say as well, this program was recorded. So if you had to jump off for any reason, if you missed anything or just want to go back, we will be sending this recording out via email to everybody who registered for today's program. We'd also encourage you, once the meeting closes, a window will pop up on your screen. It's an evaluation, and we'd love your feedback. So please be sure to complete the survey right after the program today. Your feedback really is important to us, and it helps guide our programs in the future. So please be sure to do that. And again, thank you to our sponsors, Kiowa Kirin, Amul, and Boston Scientific. It's really thanks to our corporate partners that these programs can happen. So we're really fortunate to have their support. So thank you again to our sponsors today. All right, and please know that you are not alone in this. Our respective organizations are here for you, and we look forward to connecting with you. If you have a question that was not addressed today during the Q&A, please do reach out to the Parkinson's Foundation helpline Monday through Friday with Parkinson's related questions, and that number again is 1-800-4PD-INFO. You can also email our helpline team, and they are very quick to respond, so definitely take advantage of that resource. You can certainly also contact your local VA medical center. So thank you again for your service to our country. We hope that you do enjoy the rest of your day, and hope that you'll join us for a future Parkinson's Foundation webinar. So thank you, everybody, and have a wonderful afternoon.
Thank you.
Thank you.
Yeah.